A very good afternoon from lung to the heart. So I wouldn't say it's a rare case, but it's a very successfully managed case with the help of a very expert multidisciplinary team who managed the excellent case and a very successful outcome for not only mother, for the child, for the baby also. So I'll request Dr. Rajesh and the team of Dr. Monica who have successfully managed this case to come and discuss this case.
Thank you, ma'am. Good afternoon, respected faculty member and dear residents. Today, we are here to discuss a case which was a formidable challenge for us, and the honors to save 2 lives was on the team, which was managed successfully with the sincere effort of all the concerned departments. From cardiology, Dr. Sandeep Seth, Dr. Saurabh Agustam, and from CTVS, Dr. P. Raja Shekhar and team, and from cardiac anesthesia, Dr. Sambhunath and team, and from neonatology, Dr. Deepika. They have helped us to manage this case. So now I request Dr. Pooja, our senior resident, to present the case, and Dr. Monica will further discuss about the management of the case. Thank you.
Thank you, ma'am. A very warm good afternoon to everyone. Our patient, she was a 36 years old female, gravida second, previous one abortion at 30 weeks of POG. She was a self-referred from a private hospital with the chief complaint of breathlessness since 2 months with progressive swelling over whole body for 1 month. She had difficulty in breathing for 2 months, which was gradually progressive and was aggravated in last 4 to 5 days, with associated with chest tightness, and swelling was initiated from both lower limbs, which progressed to whole body over 2 months, and it was also associated with significant weight gain. Coming to her first trimester, it was a natural conception. She was diagnosed with gestational hypothyroid and was started on tablet thyroxine 37.5 micrograms, and the first trimester screening, dual marker and NT-NB scan were negative. During second trimester, she was a booked case in a private hospital and oral glucose tolerance test was deranged, so injection insulin was started. Targeted imaging for fetal anomalies scan was done, which was also negative. She had been married for 4 years and her previous pregnancy was terminated in view of multiple anomalies detected on TIFA scan, and for which it was medically terminated 3 years back. She was a known case of bronchial asthma and her salbutamol inhaler uptake was increased from 4 to 5 times a day to 7 to 8 times a day during pregnancy. She was also reformed smoker and reformed alcohol occasional alcohol intake. Yes, sir. So, a reformed smoker is in her lifetime, she has smoked 100 cigarettes, and from past 1 year, she has stopped smoking. Yes, sir. So, in this case, since 15 months, she was not smoking. And same for this also. Whether she was not taking, before she was taking occasionally, like on weekends, and now for 1 year, she was not taking any alcohol before pregnancy. Yes, sir. As such, her general examination was normal, which was very unusual for us with that much of breathlessness. But there was severe anasarca. Abdominal wall edema was very severe, so much so that the uterine size, fundal height could not be assessed, and even the fetal heart sound was barely localized using ultrasound. Routine blood investigations were within normal limit except for the OGTT, and her BNP was borderline raised. These were the routine blood tests done during her hospital course, and these were within normal limits. As stated before, her first trimester screening, that is dual marker and NBNT scan, were negative. TIFA scan was also negative. We did the growth scan at the time of admission, which was also within normal limit, and the growth scan was repeated after 4 weeks to see the growth centile of the baby, and which came to be normal. Her ECG and chest X-ray were also normal. 2D echocardiography done at the time of admissions, suggestive of global left ventricular hypokinesia, mild MR, and ejection fraction of only 10 to 15%. While on subsequent repeat echocardiography, the dilated left ventricle, there was global dilated left ventricle hypokinesia with moderate MR and TR, but the ejection fraction was improved to 20 to 25%. So, analyzing her history, examination, and investigation, we sum up with the high risk points in this pregnancy was that she was elderly gravida with very term pregnancy, that is 30 weeks of POG, associated with hypothyroid and gestational diabetes, reformed smoker and alcohol drinking, NYHA category 3, global hypokinesia, and left ventricle ejection fraction of only 10 to 15%. So, with the discussion with the cardiology team, we reached a provisional diagnosis of peripartum cardiomyopathy. The patient was then admitted in ICU for a day. After stabilization, she was shifted to cardiology ward. There, the medical management was done. Injection furosemide, the combination of isosorbide dinitrate, hydralazine, tablet digoxin, and enoxaparin was started. In the ward, she was started with injection dexamethasone 6 milligram for fetal lung maturity. Now I would like to call upon Dr. Swami from cardiology team for the.
Good afternoon, everyone. I'll be speaking about the cardiological aspects of management in this case. We have managed this case under guidance of Dr. Sandeep Seth, sir. We received the patient in CCU on 4th of 9th month, 4/9/2023, and she was in NYHA class 3. So the diagnosis was clear. It was systolic heart failure, which in a pregnant patient. So we had a probable diagnosis of peripartum cardiomyopathy, which is a DCMP, that is dilated cardiomyopathy with systolic heart failure. And she had severe LV dysfunction, which is less than 30%. So, and she was in NYHA class 3. She was in heart failure, which is of a warm and wet category. And we started her, and she had borderline hemodynamics at the time of presentation to CCU. So we started her on IV diuretics with Lasix 20 mg twice a day. And since the pregnancy is a hypercoagulable state, and on top of it, if the patient is having low ejection fraction, there are more chances that the LV thrombus could form. So we started her on prophylactic dose of low molecular weight heparin, that's enoxaparin, with at a dose of 0.4 ml OD subcutaneously. And after that, we closely monitored her with regular weight monitoring, in strict input-output monitoring, and also electrolyte monitoring. And we examined her regularly, and based on clinical decision, we increased the dose of diuretics from 40 mg per day to 40 mg. We added additional dose of 20 mg, that is 40 mg in the morning and 20 mg in the evening. And basically, in a case of systolic heart failure, what we manage in a non-pregnant patients are, we use 4 drugs upfront. Those are ARNIs. ARNIs are the new class of drugs in the heart failure. They are angiotensin receptor blockers and neprilysin inhibitors. You might be knowing the name famously as Vimada. So we start that, and along with that, we have beta blockers, ACE inhibitors, and mineralocorticoid receptor antagonists. But most of these drugs, that ARBs, ACE inhibitors, and ARNIs, that is angiotensin receptor blocker and neprilysin inhibitors, are contraindicated in pregnancy, as you all know. So we are left with only the diuretics and digoxin, beta blockers, and isoleucine. So next we introduced isoleucine, which is isosorbide dinitrate, combination of isosorbide dinitrate and hydralazine with a low dose, that is half tab twice a day. And also we started the digoxin 0.125 mg, 1 tablet once daily. And also after she tolerated the diuretics, that is Lasix and digoxin, we monitored carefully, and then gradually we added isoleucine. We up-titrated the isoleucine to 1 tablet BD. Sure, ma'am. Ma'am, we have to. She had borderline hemodynamics. Initially, she had a BP of 90/60. So we were not too aggressive in up-titrating the diuretics, and we gradually updated her with the diuretics and then isoleucine. And the patient gradually improved, And we started beta blockers later, because beta blockers are usually not started when the patient is having severe congestion. So when the patient's condition is resolved, we also started beta blockers at a dose of tab carvedilol 3.125 mg half tablet OD. And she was hypothyroid. We continued the hypothyroid medications, and also we gradually updated the digoxin from 0.125 mg to 0.25 mg OD. And then when she improved, her NYHA class is also improved. Then we shifted her from IV medications to oral medications, depending on the based on her clinical status. And then after a month of stay in cardiology department, she was finally her ejection fraction slightly improved from 10-15% to 20-25%. And then we with the coordinated decision, we she was planned for elective LSCS on 3rd of October. And then we have coordinated with the CTVS department so as to conduct this LSCS in CTVS OT only.
Thank you, sir. The main challenge for us was the balance between the maternal severe condition and another versus the prevention of fetal prematurity, which may lead to respiratory distress, encephalopathy, necrotizing enterocolitis, hypoglycemia, and hypothermia. If we continue the pregnancy with this ejection fraction, we may land up with the intrauterine death, or worse, the mother may have acute heart failure. So here comes the multidisciplinary team approach. So with the combined effect and a joint, with the combined effort and a joint decision was taken to continue the pregnancy till 35 weeks as the patient was improving in the ward, and the termination of pregnancy was done on 35 weeks of gestation, and section was done on 3rd October in the CTVS OT under GA, and a healthy crying baby, male baby of 2.1 kg was delivered. Now, I would like to call upon Dr. Harshan from CTVS team for intra-op complications.
Good evening, everyone. I would like to start with whatever challenges we have faced in managing this case inside the OT. We do operate on critical cases daily, but this is a different situation on that day. We have 2 lives at stake. So the main problems that we had were if the patient she develops tachycardia or because of the sudden shift in the fluid dynamics, there could be a severe effect on the failing heart. So we were ready for everything, and the main complication which could happen was if there is a sudden decompensation, she would land up in ventricular fibrillation or sudden cardiac arrest, and she might require immediate mechanical circulatory support. So how were we prepared? The basic, most of the things were handled by cardiac anesthesia team. Thanks to them, Dr. Shambhunath sir and his team handled the patient very well. So we have taken awake lines so that we were ready immediately after induction. If there is any problem, we would go on mechanical circulatory support immediately. So we have taken awake lines, arterial line and central venous line. All these lines we routinely take in our cardiac surgery cases. So we have put them initially before the induction itself. We have also attached, we have also put her on NIRS monitoring. This is for the neurological monitoring inside the OT. And external defibrillatory pads were also attached, paddles were also attached. So CPB circuit, cardiopulmonary bypass circuit, and pump were ready along with a perfusionist. Blood was reserved and kept inside the OT. Our CTVS team, we were also scrubbed along with the gynecology team, and we were ready to, in case if there is any untoward event, the patient has to be put on mechanical circulatory support in less than 3 minutes. So everything was planned accordingly. We have already also draped the chest as well and kept everything ready to go on bypass immediately. But thankfully, all our efforts were not of any use. We were happy of that, and the operation went on successfully. Thank you.
Thank you, sir. Now I would like to call Dr. Deepika from neonatology for her challenges faced with a premature child.
So baby was born out of a complicated surgery, and the most important thing in this case was that it was not a usual place for us to deliver the baby. It was in CTVS OT, where we don't have the supplies normally ready. So because we were in constant touch with the CTVS team and the obstetrics team, so we arranged the necessary equipment for a preterm baby. And thankfully, this was a late preterm baby, and we could stretch the pregnancy towards 35 weeks, where the outcomes are much better as compared to a 30 weeks, as we just saw, if the baby would have been delivered at 30 weeks. So baby was born, and baby cried immediately, but baby had distress requiring CPAP support, and we had to transfer the baby all the way back to our ICU in the mother and child block. And baby was euthermic, and baby stayed with us for around 2 weeks, and was not put on breastfeeding because mother was on bromocriptine. I think we'll come to those details. And but baby is currently healthy, and the challenges are mostly with the resuscitation because we don't have some equipment like blenders in the routine other OTs, which are very necessary for a preterm baby because it prevents ROP and lung injuries. But unfortunately, we could not arrange a blender there, but we could give 100% oxygen, and we could transfer as soon as the baby was stable. Thank you.
Thank you, ma'am. And in the postpartum period, the mother was shifted back to cardiology ward after an observation in CCU for a day. The post-delivery period was uneventful, and she was discharged on day 6. But the baby was kept in the NICU for 15 days for observation, and baby was also discharged in stable condition. The follow-up echo, 2D echo, was done 4 weeks later, which was suggestive of ejection fraction of 20 to 25%. On discharge, the treatment given were the tablet bromocriptine, as stated by ma'am. It was 2.5 milligram, 1 tablet twice a day. So the lactational separation was, so the baby was on the top feed. Losartan, aldactone, torsemide, digoxin, ecosprin, and altroxin. Now I would like to call upon Dr. Monica Sahu for further discussion.
Good afternoon, everyone. As we all saw that this case was rare only in terms of the clinical features. She had a generalized anasarca and the vitals were stable. With the help of all the teams, we could manage her successfully. As we all know, peripartum cardiomyopathy is a form of systolic heart failure with reduced left ventricular ejection fraction in women of childbearing age, which occur without any known cardiac disease already in the last months of the pregnancy or in the 5 months following delivery. The incidence is very rare of 25 to 100 per 1 lakh live births worldwide, and in India it is 75 per 1 lakh live births. The incidence is highest in the African countries, especially Nigeria and Haiti. Following are the risk factors which predispose a woman to peripartum cardiomyopathy: advanced maternal age, multiparity, multifetal gestation, preeclampsia, hypertension, cocaine intake, smoking, alcohol intake, malnutrition, obesity. There are certain genetic factors as well, prolonged tocolysis, and African descent. The symptoms we all saw, common symptoms are orthopnea, dyspnea, paroxysmal nocturnal dyspnea, and the uncommon symptoms are chest pain, cough, palpitation, extreme fatigue, and hemoptysis. The pathogenesis is still under research. However, this throws some light on the role of the hormonal interplay in pregnancy. So, the pituitary gland is releasing prolactin, and from the placenta we can see the soluble FMS like tyrosine kinase protein 1, and cathepsin D is formed from the cardiomyocytes. Under the effect of cathepsin D, the prolactin are broken into the fragments, and as a result of the interplay of these 3 hormonal organs, there is an increase in the level of vasoinhibin and decrease in the level of relaxin. So there is vascular toxicity, vasoconstriction, and cardiotoxicity. The diagnostic criteria, the classic features are development of cardiac failure in the 3rd trimester or within 5 months postpartum. There is no identifiable cause of the heart failure and no recognized heart disease already in the woman. And the additional feature are strict echocardiographic indication of a left ventricular dysfunction in terms of ejection fraction of less than 45% and of fractional shortening of less than 30% or end diastolic diameter of more than 2.7 centimeter per meter square. So our patient fell in the category of severe postpartum cardiomyopathy because her left ventricular ejection fraction was less than 25%. With the medical management that she received for 3 weeks, over 3 weeks, she was in the category of moderate peripartum cardiomyopathy, so that we could carry on with the pregnancy. The management options involve during pregnancy, there is a role of beta blockers, loop diuretics, hydralazine isosorbide combination, digoxin, and low molecular weight heparin. The delivery has to be planned well in advance with a cardio obstetrics team if the patient is stable. If the patient is unstable, she needs to be first stabilized hemodynamically with the help of ICU and CCU, and after optimization, the delivery is carefully planned. After pregnancy, there is a role as per literature to continue the medical management for up to 6 months to 1 year after delivery, because the molecular level of recovery lags behind the echocardiographic recovery by almost 6 months. So we expect that the woman, 75% of the women should recover in terms of the echo findings within 6 months of delivery. However, the molecular level of recovery in the heart lags behind by 6 months. So we continue the medical management for a year at least. The outcomes depend upon a lot on the descent also and the initial findings. So there can be worse prognosis with lower left ventricle ejection fraction. As in our case, it was 10 to 15% and a dilated left ventricle. Long-term outcomes, in 75% cases, there is recovery, and in 25% cases, there can be worsening and recurrent peripartum cardiomyopathy. So this is the regimen of bromocriptine, oral heart failure drugs, anticoagulants, vasodilators, relaxants, if they're required if the systolic blood pressure is more than 110 millimeters of mercury, and the loop diuretics. Prognosis, the risk of subsequent pregnancies depends upon the myocardial recovery. So we need to follow up the patient with a follow-up echo. For our patient, she now 4 months post-delivery, and the echocardiography has not been done after 4 months. It was done at 1 month of delivery, and there is no change in the ejection fraction from her diagnosis stage. If the left ventricular ejection fraction improves and it is more than 50%, then the rate of death in subsequent pregnancies is less than 1%, and recurrent heart failure is less than 10%. However, if the left ventricular ejection fraction does not improve and it stays less than 50%, then there is a very high rate of heart failure, which is 25 to 50%, and also a 10% risk of death in subsequent pregnancies. Now we review the literature. So there are a lot of papers regarding peripartum cardiomyopathy. However, we'll discuss 2 papers which are following longitudinally a high number of pregnancies. The first one was published in the American Journal of Obstetrics and Gynaecology. It is maternal pregnancy outcomes in women with cardiomyopathy. It's a systematic review and meta-analysis involving 57 million pregnancies. And they found that there is a severe maternal cardiovascular events and in-hospital mortality in patients of peripartum cardiomyopathy with an odds ratio of more than 100, and high likelihood of cesarean section with an odds ratio of more than 2.9. Then there is a 20-year population study of peripartum cardiomyopathy in the European Heart Journal, which is a retrospective observational study of 8.8 years follow-up. And they found that the incidence of peripartum cardiomyopathy was 1 in 5,000 with 8% death rate and 75% rehospitalization. And 76% were found to have left ventricular ejection fraction recovery. And there was a 12 times higher mortality. And even the children of these mothers had higher incidence of cardiovascular disease and 5 times mortality. So coming to the take-home message, peripartum cardiomyopathy is a rare pregnancy-related disorder, and we need to have a high index of suspicion because it is usually diagnosed only with severe symptoms. There is a high incidence of cardiovascular events and in-hospital deaths, and hence we can manage it with multidisciplinary team approach, and there is an expectation of 75% recovery within 6 months of delivery.
Thank you, Monica. Without a team approach, this case was not successful. So, my sincere in the obstetrics and gynecology, Professor Basla and team and all the gynecology department has helped her. From cardiology, Professor Sandeep Seth and team managed this case. From cardiac anesthesia, Professor Dr. Sambhunath Das and team. And CTVS, Professor Dr. P. Rajashekhar and team, and neonatology from Dr. Anu and team. Now, I would like to request Neeta Singh ma'am to give her valuable opinion. And ma'am, Neena ma'am, you want to say? Questions from the house.
Bromocriptine.
Bromocriptine. She was on bromocriptine.
Another for the heart. This question is for the cardiologist. I'm sorry. Yeah. So the patient was discharged on aldactone, losartan, and bromocriptine. So wouldn't the patient have benefited from starting enalapril for long-term cardiac modulation after delivery? After delivery.
Ma'am, we have started around losartan. The ACE inhibitors and angiotensin receptor blockers both have comparable benefits. So we have started around losartan because she used to have a little dry cough because of the lung congestion and all. So we started around losartan, which is comparable with the benefits.
And her ejection fraction also was 20 to 25%. And that generalized NSF and dyspnea and all those things. If she will, maybe I think she will more deteriorate than baby was situated before. And bromocriptine. Oh, she was not breastfeeding. She was not breastfeeding. She was on top weight. तुझे भी टॉप वेट लास्ट फोटो भी दिखा तुमने उस पेशेंट का बोलो 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 हाँ लास्ट फोटो दिखा
So,
we have given her contraceptive advice. She refused right now. She said, I will come, then I will discuss with you.
it was a collective decision of the couple. They did not accept any contraception. Yes, ma'am.
There are chances. There are chances. There are very high chances. First maybe कुछ था Thank you, sir.
So I would like to add on the role of bromocriptine. Actually, there is a large multi-center trial which is going on right now. It is the Rebirth trial on the role of bromocriptine on the improvement of cardiomyocyte function. It will be completed in 2026, and then only we can have evidence from randomized control trials on the feasibility of giving. Right now, the evidence is from patients of 20 to 60 patients only of small RCTs. So the latest publication that has come in NEJM only 5 days back says that the role of bromocriptine is awaited from this trial, which will be completed in 2026. Yes. So it was a collective decision made by the team of cardiology and neonatology to top feed the baby and start the patient on bromocriptine with the hope that it will improve the cardiomyocyte function. Thank you. Thank you, everyone.